Great, Shira. Thank you so much. Okay, great. Recording is going. Welcome, everybody. We are so excited today to bring you this information session about menopause and perimenopause. And we are joined by Dr. Naqvi here, who is an obstetrician gynecologist with Atlantic Health. So she has an incredibly impressive resume. So I actually am going to read an intro for her. Just, yeah, just want to make sure I do it justice. So, um, without further ado, Dr. Naqvi is an obstetrician gynecologist with Atlantic Health System. With over 20 years of experience, Dr. Naqvi approaches her practice with kindness and understanding, putting patients at ease during exams and procedures. She treats women of all ages, providing the full range of labor, delivery, and postpartum care, as well as expertise in all aspects of women's health, from the adolescent to the mature adult. She is especially passionate about teaching young women about their developing bodies and reproductive health. Dr. Naqvi earned her medical degree from SUNY Upstate Medical University and completed a residency in obstetrics and gynecology at Christiana Hospital. Committed to education and service, she has delivered over 75 lectures on all aspects of women's health to residents in obstetrics and gynecology and served on a mission trip to Iraq, focused on the health needs of Iraqi women. She is a participating provider of the Atlantic Accountable Care Organization. And that is the short version of the bio. So there's actually a lot more that I cut out for time's sake. But we are so happy and excited to welcome her today. She has a wonderful presentation prepared for you. So just to go over the agenda, um, we will let Dr. Naqvi give the presentation, and then the last maybe 20, 25 minutes or so can be a Q&A. So of course, at that time, everyone is welcome to unmute, ask questions. And then I also have some questions prepared as well if there's any time left over. Okay, so I'm going to share my screen here, and then I will go on mute and let Dr. Naqvi take over. Okay,
Perfect.
Dr. Naqvi, the floor is yours.
Thank you, Gina. First off, I just want to thank the organizers for pulling this information session together. I think it is very important for us to talk about this and to have conversation and dialogue. And it could just be the beginning of something much bigger. But most importantly, I want to thank you all for joining because I love to talk, but I don't like to hear myself. So it's nice to have an audience. So first of all, thank you for each and every one of you who has joined for this information session. But as we know, the many different ethnicities make up the Asian American experience, and how but one unifying theme sometimes that I see a lot in my practice is how the experience of navigating as a first generation Asian American or a second generation Asian American, like how are you interacting with the complex healthcare landscape that is the American healthcare, right? It is not easy to navigate. I know from my own background, I am a first generation, and it's very difficult understanding. You could be a very highly educated person, but you still will face barriers and struggles in trying to understand not just the insurance landscape, but how do you enter the ER, how do you navigate things. So it is a very different lived experience that we all have. And this conversation is part of my passion to address that and to make sure that we empower.
Okay, Dr. Naqvi, on my end, I think your audio just cut
Oh,
out. Will
I
you
said
just,
next slide. That's
oh,
all.
there you go. Okay,
Oh, this says
perfect.
I
Okay, now we
can't.
can hear you.
You can hear me okay? Okay.
Yes, now I can hear you. Perfect. Okay, great. Here
I
we
was
go.
just giving you guys all the positives and acknowledging you missed all of that now.
No. It was just that last like couple seconds. Yep, so we're good
Okay.
now. Perfect.
So this is a very complex slide, and we're not in science class. I don't need anyone to, understand this. But if you do, fantastic. but it is to highlight the complexity of the female cycle, the menstrual cycle. And it is what's really important to note is at the top of the slide, it's the brain, right? So the brain is sending out chemical messengers called hormones that directly impact our organs throughout our body. And you have to understand how complex this cycle is in the female, is at the same time things are happening in your ovaries. At the same time, things are happening in your uterus. At the same time, feedback is being provided from those set of organs back to the brain so it can be modulated and in turn responds appropriately to what the local environment is to.
Again. I'm so sorry. I think your audio
Sorry.
is cutting out
Oh
again.
no. Okay,
If you just want to backtrack like a few seconds.
sure. So I was saying that
Okay.
it's just the complexity and how the local environment is also giving feedback to what's happening locally, and then the brain is obviously modulating that and addressing it in a real-time fashion. So all of our cycles are very unique every single month because we're just in a different body every single month. But the key element here is also that multiple things are happening at the same time. The brain is in charge of our body, right? So the brain communicates with the rest of the organs by using, like I said, chemical messengers called hormones. It controls pretty much everything. And what I mean by that is it tells the ovary what to kind of do, what to expect. And then the ovary then tells the uterus kind of how to respond in a timely fashion. This complexity goes awry in perimenopause. So that's why this is what a normal cycle looks like. And imagine what's happening in our perimenopause. And I'll go through the definitions in a second, is what is going awry during all of this. So there are many points in this cycle that things can go, lack of a better word, bonkers, right? So our hormones are all over the place, our ovaries are not listening, quote unquote, and we bleed abnormally. So next slide. So why does the human body undergo menopause, right? So we're going to talk definitions for a little bit. So menopause is essentially you stop bleeding forever after you reach a milestone of no bleeding for one whole calendar year. Once you reach that milestone, that is called menopause, okay? But why? Why does it even exist in our, right, in our biology, right? Why does it even happen? So nobody really truly understands why this is a unique experience to humans, right? They think the hypothesis is called the grandmother hypothesis, that, and I don't know if in our community here, if it'll echo or not, but essentially grandmothers, right? So the theory is that we stop reproducing and we focus on raising families, raising the next progeny, the next generation. So if you think back to hunter-gatherer societies and how we evolved from that, that we really survival was our utmost priority, right? So now moving forward, that's still echoing. And is this an evolutionary process where now families, right? So the grandmothers are raising children while the adults, meaning, are going out there instead of hunting and gathering, where some might do still, but we're out there earning a living and, doing our daily jobs and errands and whatever has to do. But is that the reason behind it? So I just wanted to mention that grandmother hypothesis a little bit about why there may be a biological basis for why this exists in the humans. So here's a chart, and again, it's very complex, but just to kind of streamline it a little bit, this is called a straw plus 10. So research has gone into this and I tried to synthesize a sort of like a roadmap of what our bodies will go through in the female. So at the top, it's called a menarche, and essentially make that stage zero. That's essentially when we start menstruating. We've reached puberty. And then we go down the slide towards the right-hand side and we reach that menopause, the definition that I just went over. If you look through it, the reproductive ages, the second row that talks about reproductive, that's when we're kind of like going through our teenage years. That's when we're maybe having kids. That's where, if you are interested in having and creating a family, that's where all of that is happening. Finally, when you're about a year to 3 years shy of hitting that menopause milestone, that's what's called perimenopause. It's that transition that's happening. And during this time, it is a very, very different experience for every single person. So you may start noticing subtle changes in your menstrual cycle. The flow changes. It's not happening every time in the fourth week of the month. It's tweaking a little bit. You start feeling a little bit, different. And then finally, you get to that perimenopause, and now your cycles are totally unpredictable. You don't know what's going on. Why do you feel this way? When your period is coming? What's happening to your body? Feels like you're having an out of body experience. And then finally, you stop bleeding, and then you are basically considered postmenopausal once that happens. And even in that stage, it's broken down by early and late. The other thing I want to mention is women are always like, and there's a lot of social media about getting testing done, right? Oh, I didn't want to say social media, I should say. There's a lot of attention being placed on, what are my hormones doing? What are my hormones? When you come to the doctor's office, right, and you're like, my hormones checked, I think we know what it means. But like I said, hormones are just chemical messengers that go around the body communicating with different parts of with our brain and different parts of our body. So there is some validity, right? An indication for why you want to get your hormones checked. But for the average person, it really doesn't help us at all because it's only one data point. So you need to have a story built. But that's not the whole thing. If I get my blood drawn today at 12 o'clock on a Wednesday, it's going to read something. If I draw it at 4 o'clock today, it's going to read something different. So it doesn't really help us to predict when you're going to go into menopause. It doesn't really help us to try to figure out, oh, you're about this close to it, or you're having this severe perimenopause stage. It can guide us to some degree, but it's not the whole story. The only person that really I do hormonal testing is someone who's had their uterus removed or someone who's had a hysterectomy, because we lose that one important clue that we have, and that's your menstrual cycle. So we don't get any data from that. So we really need to know what your periods are like. But if you don't have a uterus, I have to kind of do some additional testing to kind of verify where you are. So that's where hormonal testing can come into play. And there's a bunch of hormones that are listed down there. But even the symptoms that you feel during perimenopause and menopause can differ by, believe it or not, by different ethnicities too. And you follow a different path too. Some women have peak symptoms of perimenopause in meaning hot flushes, night sweats, and I'll go into that in a little bit, what you feel earlier. And then they don't feel anything after they transitioned into menopause. Some, it's very correlated very nicely in a bell-shaped curve, is as soon as you hit that milestone, your symptoms peak. And there's some who are late, I would say, bloomers, and it kind of symptom peaks towards after they've transitioned, okay? So really, this is more about just kind of laying out the landscape basically from puberty to when we stop bleeding. The one key element that I want to also mention is you don't see age anywhere. There's no age mentioned on this chart. And that's important, right? Because age is just, we don't need to fixate on age, right? So different ethnicities actually experience menopause at different ages too. So the white Caucasian may averages studies have shown is between 51 and 52. For Black women, it is around 50. For Asian Hispanics, it's 48. And I'll tell you about the Asian American experience in just a little bit. But just showing there's variety, and that's why age is never part of this, because a woman can go through menopause at the age of 40. Okay, that means she will experience a lot of these symptoms in her late 30s. And that's a different conversation. And they did look at ethnicities, right? And why these women experience such different experiences. So there was one study back in the day called the SWAN study, and they really focused on the African American experience. And they found that women will experience perimenopause at a much younger age, but they still transition and go into menopause at age 50. That means they have a whole lot of years prior to that, not just the 1 to 2, but they may be in it for a little bit more than 10 years, even, okay, that they're experiencing this. And you're like, when is this menopause happening? At that point, you might be frustrated by that. But it's important because the more your body is under that transition, it has implications. So just key points from this: different transition phases, no hormones testing indicated, age is not part of this, neither is your BMI, neither is your socio-demographic information. It is very basic biology that we're talking about right now, okay? Next slide. Great. So in the perimenopause, now I'm going to kind of break it down a little bit. So in perimenopause, and I mentioned we're not going to talk about age, but we're talking about what is also happening around us, right? So this is when most of us might be experiencing career changes. We're looking for new jobs. We're hopping around. We're looking for motivation. We're looking for direction. Maybe you want to take your life in a different way. Maybe the experiences you've already had will be directing you to pursue other avenues. We're also part of a sandwich generation, right? So depending on how old you are, or it depends. Sandwich generation just means that you are taking care of elderly family members and raising your children, right? Or other members that are younger than you that you're raising them, other family members. So you're kind of like in this sandwich where you're like, gosh, I got to take care. Like I'm part of a sandwich generation. My 84-year-old mother, I have to worry about her all the time, right? What's going on with her? What's her medications? But then I have younger kids, right? And I'm like, okay, college is coming up, or we're, handling elementary school. We've got, no one sits around here, on weekends. We're always doing some sport, something, involved. So you're always going, and imagine that's just life stressors, right? And during this time, you're still trying to navigate what your own health is all about, and you're trying to focus on that. And here comes essentially perimenopause. Now your body is biology speaking, right? And now you're like, oh gosh, what's happening to me? And you are basically your body is undergoing multiple changes at the same time. I've listed some right here. So you start noticing fluctuations in your weight, right? All of a sudden, you start noticing, my gosh, I'm putting on more weight where I could just starve for the weekend for the wedding and lose a few pounds. I'm not able to do that. Or I could stop, eating this, and I'll be good. I'll be less bloated. Those strategies have gone out the window for me, my friends, okay? In all honesty. So you start noticing you're putting on weight more centrally, more in your abdomen. You start noticing skin changes. Your skin is getting more drier, right? Even our face structure starts to change. We start to lose a lot of fat and muscle and, a lot of this stuff. So your eyes kind of look sunken in. Meanwhile, you lose your cheekbones. It starts getting rounder a little bit here. And this is all part of what's happening even as we speak. Your hair starts thinning out. You start having like, my God, this happens to me all the time. If I don't write it down, it doesn't exist. Okay. I can go from the kitchen to the laundry room and I will forget it, what I was about to do. I'm not sleeping as well. Sometimes the hot flushes, the night sweats are keeping me up, or sometimes it's just, oh my God, I got to get to work. I have to do X, Y, Z. And sometimes you notice palpitations, anxiety. Why is all of this happening at the same time? Well, the thing is that, remember, going back a couple of slides, the brain is modulating, the brain is renovating itself, okay? And there's certain phases of our lives that this happens. One is puberty, okay? Actually, our brain, and it makes sense. The brain continues to develop until we're done with our teenage years. It's continuously evolving. That's why when we're teenagers, we're very instinctual, right? One part of our brain is dominant more so than the other, but it's fine tuning it. as we progress and enter our 20s or so on, so when we become adults, it starts to, again, now you're having kids. Pregnancy will change your brain. Actual pregnancy will change the brain mapping and how your brain is structured. And then finally, when you hit menopause, it actually changes even more. And there was a recent study that people have been commenting on that you can actually see structural brain changes that occur because of menopause. And the thing is that we talk about estrogen, but our body doesn't make one estrogen. We actually make a few estrogens. But it's the estradiol, that one particular estrogen, that is what our body likes and was used to for so many years. And now that ratio is changing. So that estrogen is being made less and less by the ovaries. And the other estrogens are still there. Our ovaries are never dead, by the way, okay? They're always working, but you just don't feel the effects of it. So as the estrogen ratios are changing, that's why this body experiences all these symptoms. And it takes, believe it or not, there are over 50 plus different symptoms of perimenopause and menopause. So you can just imagine estrogen is basically in every part of our organs, every cell, it reacts to it. And hence, when there isn't our favorite estrogen around, we feel the impact of it, okay? And that's why these symptoms manifest. Next slide, Gina. So we're going to dive into essentially two major symptoms that I see a lot in my office. And I love my heading here because it's so true. It's burning, sometimes it's cold, I can't think, everything is happening. So we thought that, the previous thought was that our hot flushes, our night sweat, what we call vasomotor symptoms, occur because there's a deficiency of estrogen, that essentially what I was talking about, that our ovaries are making, they're dead and they're not making. But then if that's the case, and if this is biology, then all of us should experience it, right? If that's the key premise, that ovaries are not making enough, then all of us should be experiencing, but that's not the case. Not all of us experiences, hot flushes or night sweats. They kind of go on by, but you feel other things. So now more and more studies have come out and focused that there's actually, the brain is the center of this, that there is an area in the brain that controls our body temperature. And it's the alterations in there because of our favorite estrogen not being around that happens. And how sensitive we are is determined genetics, how we interact with the environment, all of that goes into that play. And because we discovered this allowed us and the industry, the scientific community actually, to bring about new non-hormonal medications on the market to address this for women. And I'm thinking of one specific patient population, the breast cancer patients, right? Like they would go through this and they would have nothing at their disposal. So for me, this was like a game changer for that patient population. So, but why, and why do we care? Why do we want to address? Why do I, as a doctor, want to know if you're feeling this way or not? Well, the reason is because we noticed that, risk factors such as obesity, whether you went through surgical menopause, that means your ovaries were taken out as part of your hysterectomy, or you underwent natural menopause, it does make a difference on the severity of how you experience those hot flashes. Being smoker, it will be bad for you. Diets in sugar, fats, not a well-balanced diet, you're definitely going to feel worse of it. And severe vasomotor symptoms or hot flushes and night sweats are associated with sleep disturbances. Well, that makes sense. If I have to get up 3 times in the middle of the night to take a shower, therefore, you're not going to feel like working the next day, or you're going to feel like interacting with people. So you're going to have more depressive or high anxiety, right? And then studies have also shown that it actually tends to have worse cardiovascular outcomes. So because of bone health, heart health, we want to know exactly how bad is it for you and how we can improve the symptoms for you. Next slide. Okay. The next symptom that I just want to talk about is the one that I don't think gets a lot of attention, which is why I made it part of my presentation today. Because whether it's for cultural taboos, whether it's not something that you want to talk about or have been part of it, is just having what we call the genitourinary symptoms of menopause. What that means is it's a collection of signs and symptoms that are dealing with estrogen deficiency. And what it means is it actually causes skin changes on the labia, the vagina, the cells inside that line the vagina, the bladder, the ureter. All of that you may experience as part of dryness. You may have irritation, you may have burning, you may have painful urination, you may even be getting bouts of bladder infections where you never had infections before. Why? Because estrogen, again, helps to maintain and prevent the dryness of the skin. It actually promotes water. It's a water attractant. So hyaluronic acid is important in our cells and our lining of our vagina to help retain that moisture. It maintains collagen in there. It helps promote a normal, healthy vaginal microbiome. Why is that important? Because you'll notice that our pH will change as we get older. So menopausal women will have more vaginal discharge than they ever did, and they will think that there's something wrong with them, but there really isn't anything. So this is why estrogen is such a big part of our genitourinary system, but it's important to talk about it too. What can we do about it, right? Like, what is it? What are the, sometimes, you just want to hear, like, what is the right way to maintain that area? Well, it's actually very simple, but it really, really is a game changer. Is basically wear cotton underwear. Well, hello, everyone kind of knows that, or go completely no underwear at nighttime when you're sleeping. Okay, so there's less irritation. Switch to 100% cotton sanitary pads. Okay, so it's less irritating to your body. Clean down there with just water. You don't have to use soap. You don't have to waste your money on feminine washes. Please don't. It's actually more of an irritant than actually doing anything and promoting good health down there. The best thing you can do is just let water rinse off and then you're clean. Pat it dry. Do not scrub. And the way I'm very dramatic in my exam rooms, I tell women, you don't take a washcloth and go scrubby, scrubby, scrubby to your face. Same thing down there. Our skin is so sensitive down there. It does not need our help. I tell women just to apply Vaseline or just vegetable oil to retain the moisture on the outside and seal it in, because that's what we need at that point. There are multiple vaginal lubricants out there for, like, if you're experiencing painful intercourse, but moisturizers are very different than lubricants. So the moisturizers actually have hyaluronic acid in them, and they help promote and retain the water. So if you go in the drugstore aisle, you'll see moisturizers are different than lubricants. So you should be doing a moisturizer at least twice a week, I say, even if you're not doing estrogen cream down there, just use at least twice a week a vaginal moisturizer. And pretty much, I've gone through the drugstore aisles and I've looked at what's available. It's pretty decent out there, so you can't go kind of wrong. But you should always talk to your doctors about which, is better. Bring it in, talk to them about it. Is this a good one or is not a good one? And the last thing I'll mention about the genital urinary system is also just the fact that a lot of us, like I said in the beginning, we might be starting our new lives, right? We may have new partners in our lives. So we always have to think about sexually transmitted diseases. We like to think that just because we are not procreating, we're not reproductive age, but we may find new partners, and it's important to make sure you still protect yourself against STDs, because you still can get some. You won't get what we call pelvic inflammatory diseases, infections that go inside your uterus and cause havoc in the tubes and so on and so forth. But you still could be at risk for HIV, herpes, and of course, abnormal pap smears, or what we call the HPV related. So just wanted to mention that a little bit, just so go ahead, Gina. So we kind of looked at a couple of perimenopausal symptoms that I see a lot in my office. Now we turn to essentially, are we all the same? Is the Asian American experience the same? Obviously, we all know the answer is no. It's such a large diaspora. We have so many sub-ethnicities, even from South Asian to East Asian. But I'm happy to report that more and more research is being done in this area versus even 20 years ago when I started my career, there was really nothing. So I'm so excited that I'm able to share a couple of studies with you. But one of the things that I want to make sure, and I think we all kind of know, and it's good for Western educated clinicians to be mindful of, that when you do have patients coming from different cultural backgrounds and experiences, that we understand and we can kind of coach or guide our conversation that appeals and is more in sync with that person's cultural values. So obviously I kind of wrote down here what, the Asian American cultural perceptions and taboos that may impact, how do you view, menopause in your own culture, whether it's a second spring, whether you're like, no, I'll just get through it, I just have to be mentally strong, or whether it's more focusing on, the yin and the yang, focusing on harmony, whether it's not looked at as a deficiency. So a lot of, it's not something to fix. It's not something, a disease that we have to treat. It is part of it. I mean, I don't know, some cultures even celebrate puberty, right? Right when we hit that milestone, I'm about to throw a big old party in my office when I go through menopause. So I'm going to be celebrating my new arrival of the 2.0 version of me. So I encourage all of you to do that. So this is one way of kind of transitioning into that. But the studies that I will show, that I will share with you, will highlight that the Asian American experience is very different. It's not so much the hot flushes, the night sweats. It's more about the back pain, the joint pain, the sleep, just the fatigue, the forgetfulness, the mood changes. That's where the data is showing. So depending on how you talk to a person when they're in the room with you, right? How do you want to address it? Say, I'm feeling this. I don't, they may ask, the doctor may just ask, do you having hot flushes? Are you having painful sex? Are you having, like if they don't go through the list, the top 10, then they may miss it, right? So it's important to advocate for yourself, to bring it to their attention that this is perimenopause or menopause. It may not be the typical what we have done. So the couple of studies that I'm just going to talk about is one is that was back in 2010, and I apologize, I'm going to refer to my notes here. So they're looked at sub-ethnic differences in menopausal symptom experiences in Asian Americans. So they looked at the 5 sub-ethnic population: Chinese, Korean, Asian, Indian, Filipino, and then there was another category called other. And it was an internet survey. The age ranged from 40 to 60-year-olds who were women who were able to read and write in English. The mean age for the Asian population was about 49. And the demographics of it, like out of those, there were about 91 women who answered this survey. And the breakdown of them was about a third of them were Chinese, 18% were Korean, 18% was Asian Indian, and about 12% were Filipino. Most of the women were married, had children, college educated, and their BMI was around 24. So not even, overweight. They were average. So what they found was that the most frequently reported symptom was actually loss of sexual interest. Then came aches and pains in the back, and actually back of the neck and skull. Forgetfulness was another one, and then the joint. Most severe symptom was forgetfulness. And they broke it down by different ethnicities. So forgetfulness was for the Chinese and the Korean experience. For Asian Indians, it was more fatigue. That was the most severe. For Filipinos, it was more the sleep changes. So then they asked, the survey asked, how do you get evaluated? How do you treat it? How do you approach this transition? For the Chinese women, it was more see a doctor, take medicine. For Koreans, it was take a medicine. For Filipinos, it was take medicine. I guess we're having a theme here. And for the Indians, it was staying mentally strong. So you can see there's some variety, some patterns forming, but not everything tells the story. So now we go into the Asian Indian experience. And this was a recent study that got published in 2025. And I love the title of it. It's an acronym, but it's called the Masala study. Love it. You can't miss it. So it's basically looking at women. And again, it's a survey, again, looking at three components only: hot flushes, urinary incontinence, leaking urine, and mood changes. They found 405 women who answered this survey. They were ranges of 43 to 78. 92% of the women had already undergone menopause, like finished it, they transitioned at 48 years old. A third of them experienced it as younger than 45 years old. And I'll tell you why that makes an impact. But most bothersome of the symptoms were hot flushes, 30%, 37% urinary incontinence, 15% was depression. Most of these women, there were two areas that the women came from: the San Francisco Bay Area and the Chicago area. So we have to be always mindful when we're looking at studies, what is the patient population and where they're coming from. And most of the women that were in the study were Indian born, so they really are first generation. And they've lived here more than 30 years. They have a college educated degree. They're high income earners. Again, they're overweight, non-smoker, very active. So kind of painting a picture here of like the large diaspora that we have and how different experiences we are. So why does it matter? Why do we care when a woman, especially for, let's say, for this study that I just reviewed? It's because if most of the women have already gone through everything at 48, and a third of them maybe already be done by 45, that means I lost the opportunity to educate them and address the cardiovascular and bone health concerns that I have for them earlier. So it's more about addressing those needs faster. There was another study, but for the time's sake, I'm not going to go into it, that looked at the Canadian population. Next slide. So we talk about, just like I said, the bone health, osteoporosis. And that is, of course, something that we do have to address in our Asian American population. And basically, osteoporosis means that you have impaired bone strength that causes or predisposes you to have future fracture. So it's important. And osteoporosis, and one key takeaway here is just it's calcium and vitamin D is not the whole story. Osteoporosis means it's bone organ. Your bone is an organ. So there's many, again, it's a whole organ disease. It's not just, oh, I'm lacking calcium and vitamin D. If I take enough of that, I'm going to fix osteoporosis. No, that's not the answer. What's happening is the bone remodeling ratio is changed. So throughout our lives, we're always building bone, destroying bone, building bone, destroying bone, building bone, and that changes where we're no longer able to build as fast as we're losing the bone. And that's what leads to osteoporosis. And the key point here is pretty much by the time we're 80, we've lost 30% of our bone mass. So it's important that we don't miss that opportunity to tank up on what we need to do with strength training, exercises, calcium, get good nutrition in, and make sure we are stocked well when we go through this change. So who are the women who can get this bone scan? Not everyone can in America. So you have 65 and older, it'll definitely be covered and indicated for you by your insurances. But it's also women who are in between 60 and 65. You will have certain risk factors that you can get the bone scan done earlier so you can identify your risk for osteoporosis. Next, I'm just going to kind of get through it because I see the time here. Heart health is also important. And I just want to, I know a lot of us focus on cancer, but heart health is the leading killer of women worldwide. So cardiovascular disease. And that is a catch-all phrase for multiple things that I have listed here, going from heart failure, heart attack, stroke, blood pressure, high cholesterol, and many things contribute to our heart health, right? And we've talked about, oh, if I'm a diabetic, I'm a smoker, or physical inactivity, they'll cause it. But what we are learning more and more is what our pregnancy history is. Or when we conceive, pregnancy history is now making more of an impact. So now we start looking at it, and I always ask women, did you have high blood pressure when you were pregnant? Did you have diabetes when you were pregnant? What was your situation like? And that's becoming more and predictive of future cardiovascular disease too. Go ahead, Gina, next slide. So another time period as we get older, so aging and obesity, two factors that increase our cancer risk in our lifetime. Age, we can't do anything about. Obesity, to some degree, we can do something about it, right? So there's a little bit of a hereditary component there too. But what we want to make sure is we're keeping up with what's needed and indicated at this point in our lives. So we want to make sure we're getting our mammograms in, okay? We want to make sure we're getting our pap smears in, and we want to get our colonoscopies in. Lung cancer, believe it or not, beats all the other cancers. So you want to make sure that lung cancer can happen even in non-smokers. So you make sure, based on what your exposures have been throughout your life, you talk about it with your family doctor. I just want to mention cervical cancer. Again, HPV testing came around about 15, 20 years ago, and it was a game changer on how we address cervical cancer screening. A lot of the women who may have gone throughout the years, and I would think that probably late 60s, you may not have been tested for HPV if you know what I mean, when you first started getting pap smears. But in the last 10 years, you want to make sure, look back and make sure you had HPV testing in the last 10 years at least twice to make sure it was negative. Okay, next slide, please. So how do we approach this change? So we approach it through our lifestyles. We talked about essentially how do we live a healthier life? How do we prep ourselves for this future phase? We can make dietary changes. So the two diets that I mentioned here are the DASH and the Mediterranean diet. The DASH diet is actually in studies, in scientific studies, they've been associated with less cardiovascular disease, less stroke, colon cancer, and it's really powerful for patients who are experiencing PCOS. I will give you permission to Google DASH diet. You can look through it. Otherwise, I will not tell you to go to Google, but you can do Google and Mediterranean diet. Most people know what that is too. Certain approaches to lifestyle. So one big question I get all the time is what supplements to take? What do I focus on? And I will tell you, please don't waste your money. Don't. All you need is a healthy diet. Your body knows what micronutrients, what vitamins to take from food sources rather than supplements. Number one, supplements, you don't know the quality, the purity, the safety, and how do you even know what's in there is going to the target organ that you intended to go to? You're just taking a pill. It gets digested. Where does it go? I have no idea. It goes somewhere in the body, right? You think it's going somewhere, but you don't even know. So for those reasons, we stress as physicians to focus on your diet. So the calcium vitamin D story, that's a pretty good one. So I will say, yes, you should be taking at least calcium and vitamin D. And the amount that you should be taking for a menopausal woman would be 1,200 milligrams of calcium and 600 of vitamin D. Magnesium is another good one. It's important it helps with migraine, but it also helps to absorb calcium. There's a magnesium citrate. I wouldn't take that one. That'll cause you to have to go to the bathroom frequently. It's a stool softener, so don't do that one. But the other magnesiums are good. The omega-3s are good. So omega-3 comes from fatty fish, walnuts, flaxseed meals. So again, more focusing on food sources. If you are concerned about the mercury in fish from fish sources, then that's actually a supplement of omega-3s you can do. It's probably there won't be any mercury in it, so it's actually safer for you. Coenzyme Q, it's important your cardiologist or your family doctor may have mentioned it because it actually is beneficial in for your cardiovascular health and for lowering blood pressure. But you do not want to just go out to Walmart and buy all these supplements. Talk with your doctor first and make sure it's appropriate for you. And of course, last thing I'm going to mention is obviously how we approach our transition, talking, building communities, talking about it, which is why I really, truly appreciated this avenue, this venue that was opened up for me to talk about it to our community members. And the last thing, next slide, Gina, is we get to the treatment approach, so we talked about, we looked at that one study, like, is there a medicine for it? People go to the doctors about it. So remember, the medicines that we're going to talk about now, they're built on that foundation of good nutrition and exercise. Okay, it's never in lieu of or a substitute for, it's always building upon that. I will kind of get to the punchline essentially to say that it is safe for women to take it, especially women who are under the age of 60 or less than 10 years out from their menopausal, milestone. It does improve your vasomotor, hot flushes, night sweat. It does help to stabilize your mood. It prevents bladder infection, all the things that we just talked about. The big study that came out about 20 years ago was I am of that generation where I had to take women off of hormone therapy, and it was so devastating but at that time, that's what we had. But I'm so happy to report that subsequent studies have come out to prove its safety profile and to say, that we should be talking more openly about it and how it can actually be very helpful and very beneficial. The point of this is that you have to start, if you're going to use hormones, you have to start sooner, not later. And that's why you want to get into your doctor's offices. So the next slide, James. So the non-hormonal methods that there was another slide. Oh, okay, well, that's okay. There was one slide missing. That's okay. The non-hormonal methods that are available are basically the one that, remember I told you, that works on the brain. It's because it's a different one. It's called Veoza, the purple. You may have seen ads for it. Your antidepressants, your Lexapros, your Zolofts, anti-anxiety medication, your Effexors of the world can actually help you too. You can use a medication called gabapentin, which a lot of people have because of fibromyalgia or joint pain, or they're using it for when they go see their rheumatologist, they may be prescribed that. And the newest kit it's not a new drug, but it's a novel treatment, is for, it's called Detrol. And if people are old enough, they'll know it's a trade name at that time for a incontinence medicine that people use. So you can fix your bladder issues and get rid of your hot flushes at the same time. I think that's a win-win. And then of course, there's always room for cognitive behavioral therapy. And actually hypnosis has been found in randomized controlled study to help with hot flushes too. So pretty much that was it. Sorry, I had to rush through the last 3 slides, but I really wanted to get to the questions that are probably going on in the chat that I haven't been looking at.
Thank you so much for, that entire presentation. I almost wish that we had like an extra half hour just so you could get into some of the
Yeah.
slides that maybe, we glossed over a little bit. But it was that was so wonderful. And like the chat was like very active as you were talking the entire time. And my apologies, like there was one more slide about the non-hormonal
Yeah.
methods at the end there. So we had a few I'm actually going to stop sharing
Yep.
just so that we can all kind
Okay.
of like see each other. So we did have a few questions coming in
Sure.
through the chat. Some of it I think you kind of touched on as you were speaking.
Mhm.
So the very first one we have is, in a case of a 40-year-old client with lifelong irregular menstrual cycles, periods occurring every 60 days or more and never being regular, how can we distinguish between her usual irregular pattern and the early symptoms or onset of menopause?
Yeah. So it is a tough one, to be honest. But one key aspect I will mention is I don't know if this person may have PCOS or may have increased. There may be other medical conditions that predispose the patient to have irregular cycles from maybe not ovulating regularly. So then the question comes for insulin resistance, prediabetes, and all of that. But believe it or not, people who have PCOS, there will be a time period in perimenopause where the cycles become regular. And it's just for that short duration of time. All their life, they've been irregular, and all of a sudden they become more predictable, and then they go transition into menopause. So it's a little bit of nuance, and you do may in this case, you will rely on her other symptoms as well as you may want to do testing. Again, these are the nuances. This is tailored approach to perimenopause and menopause. You can't just apply an algorithm to it, but hopefully I answered that question.
Yeah, great. Thank you. And then another one we got in the chat. We spoke about the supplements a little
Yes.
bit, but it was generally as you start the aging changes, do you recommend certain supplements? Not meaning name brand, more of what women will need more of. I read that B complex is ideal. And we discussed this a little bit, so if
Yes,
you want to.
exactly. So those are the ones that I've kind of gleaned when I made the recommendation for calcium, vitamin D, magnesium. The Bs, the vitamin Bs are there, but you have to be, again, you don't have to take supplements, honestly. If you focus on your diet, you will get what you need, your body will need from it. There's some women who are anemic, have a low blood count for many different reasons. And one of them could be that they're deficient in B12, especially women who don't eat meat or animal protein. So you will miss out on that. So you do want to make sure you are getting tested for that, and you bring it to your doctor's attention that, yeah, I actually follow XYZ diet, like I don't eat a lot of meat and I focus, so that they can test you and replace it. So yes, there's part of that. There are other B complexes, but like I said, you don't need to go out and really get it. There's a big focus on niacin again for cardiovascular health too. Again, I would defer to the family doctor to see if you really need it or not as part of your overall cardiovascular health.
Great. Thank you so much for that answer. I'm just scrolling through really quickly because I know we only have a few
Yeah.
minutes. So maybe what we'll do is we usually send a follow-up email to the registrants, and like maybe some of the
Okay.
unanswered questions we can just have you like type out an answer, and at
Yeah,
least,
sure.
so it
Yeah.
doesn't, so I hope no one thinks that I'm like not taking their question on purpose. So I'm just seeing just from scrolling through, if you have not had children, could you experience leaking urine during perimenopause?
Yes. Yeah. Look at me. I was like, yes. Even if you didn't, if you didn't give birth, you didn't carry a pregnancy, yes, because of the changes that are happening locally from the estrogen of withdrawal, or the type of estrogen that we talked about not being around there. But yes, I did want to just. There was one question about the black box warning that just was
Yes.
taken off of the HRT. I forgot where I saw that question. Oh, what are my thoughts on it? So I think, people who've been doing women's health, we've been prescribing it, right? Like we've just making a tailored approach. I don't know, when physicians talk to their patients, we have a one-on-one relationship, right? So we talk about the good, the bad, why we think it's important for you, and so on and so forth. But the black box, I don't know how much of it was really truly a deterrent. Like how many women will not take it because it was a black box warning, right? Because we've been talking about it, we've been prescribing it, it never went away. What I think made more, what will and is making more of impact around menopausal awareness is the fact that fem health industry, the fact that we're even talking about it on this, in this venue that we're talking about at AAPI, right? It's more creating that space that's going to get us where we need to talk about it, right? So the black box warning, yay, coming off of it, it really doesn't make or break my case for who I'm going to give it to and who I'm not going to give it to. But public perception is important. So, I mean, it's good, it's off, but it didn't really change my life one way or another and how I approach women. Yeah, I wish for bone scans it would be covered because I really do think it's a disservice because we're losing so much muscle and bone mass right at the time that it would be important to know what our baseline is. So I do think it is a disservice for that. Yes.
Okay, I'm gonna ask one more question, and I see everybody in the chat. We'll find some way to get the answers to you because
Yeah.
there's like so much good stuff about specifics. But Dr. Naqvi, like I'm just laughing here because we like among just like our younger staff members at API New Jersey who are maybe listening right now, we're all kind of like listening to you and going like, oh my
Yeah,
gosh, like what is going to happen to us in 10, 15, 20 years? So just to circle back to the theme of, menopause being a power surge, what can you speak as far as
so
like the positives or anything
absolutely.
else?
So, it's also how we approach our lives too, right? Like, what direction are we thinking of going, right? So this is not um this is why I'd say, what happens? We celebrate puberty, we celebrate pregnancies, we have to celebrate menopause. That's how I look at it for myself, right? I'm navigating it through it right now. I'm armed myself with information. Well, obviously I read about it, but I'm telling you, the lived experience, what your body goes through, is very different than what textbooks say. So, it's very, very different. And to be able to talk about it openly is important. As young women, I think the fact that our generation is creating this safe space and giving you information empowers you. Because when I was going through it, I had nothing to go by except I just thought my mom was going crazy and yelling at me all the time. Okay. But now that I look back, it's more about maybe she's going through this change. So that's where it comes. You're armed with knowledge. You have more studies at your disposal. You have more Asian American, Black, everybody's talking about it. It's in different venues, different podcasts, different everything. So I think you guys are ready to accept the changes that will be coming, and it's not to be afraid of it. It is part and parcel of who you are. So going to be different, but it's going to be good.
Beautifully said. I hope that to at least like our little group of
Yeah,
younger staff members who are talking, I hope that's a little bit
I know.
reassuring.
You're like, where did
Um,
I start and where I'm going to end up? But it's not an ending of anything. One other final note, just for
yeah,
our
please,
audience,
please.
we spend 40% of our lives in menopause. So this is not the end. This is just the beginning of your next phase of your life. So it's time to let go, shed the past, and move forward. So thank you so much.
Thank you so much again for the wonderful presentation. Yes, claps all around. And I mean, I really feel like we need like I wish we had like a two-parter here because
No,
there's so much information to cover. But thank you to everyone who joined, who's listening on right now. I know that there's a lot of folks from Atlantic Health and a few of our staff as well. So and everybody else in between. So thank you so much, Dr. Naqvi. It was truly a pleasure having you. And please look forward to that follow-up email for our participants. Okay.